Otherwise, we can have the next session with the final remarks.
Yes, so we'll move on to the keynote lectures, and I invite none other than the Secretary of Diabetes India, Dr. Banshi Sabu Sir, and Dr. Mithun Bhartia and Dr. Rakesh Parekh to chair the session. Dr. Banshi Sabu Sir needs absolutely no introduction because he is he's the absolute face of conferences in India and even internationally now. Dr. Banshi Sir, please take over for the keynote lectures.
So, Purvi, what we have decided whether we will get first Dr. V Mohan or Dr. Michael Nock?
I think Dr. Nock is right here. So, sir, is that okay if you can just unmute yourself and also switch on the video? We can have your talk first.
Dr. V Mohan talk is recorded once, so you just ask Michael Nock whether he's comfortable now or will he be joining little later.
No, that's fine. I'm fine with starting.
Great.
So I have
That's great.
I have to share my screen, I guess.
No. Before that, Neelam is sharing your CV. Dr. Purvi, please introduce Dr. Michael Nock. Then we are really thankful to him that he could join live and giving talk for our World Congress of Diabetes India.
An absolute honor for me to introduce Professor Nock, who has particular research interest in the role of gastrointestinal peptide hormones, incretins, GIP, GLP, and the rest in the physiological regulation of metabolism and has volumes of work in the field. He has contributed pivotal studies proving a therapeutic potential of GLP-1 in type 2 diabetes, also contributed to the development of incretin-based glucose-lowering medications such as GLP-1 receptor agonists and inhibitors of DPP-4. Additional areas of interest include spontaneous hypoglycemia, pancreas transplantation, cardiovascular complications, and so on and so forth. His scientific contributions have been honored with several awards, including the Ferdinand Bertram Award in 1993, the Werner Creutzfeldt Award in 2007, and the Paul Langerhans Medal of 2012 of the German Diabetes Association. He has served as a reviewer for all major diabetes journals and published extensively in books and peer-reviewed journals, including original articles, and has been quoted more than 57,000 times. His H index is 102, and he has been a highly cited researcher. Was voted amongst that in 2019. Professor Nock is also a member of a number of professional societies, including the German, European, American Diabetes Association, and the International Diabetes Federation. Without much ado, sir, we welcome you to Diabetes India, and it's an honor to have you with us.
See, I think someone has to.
Alex, can you please give the right
sharing the.
Yes, sir. You can share your slides, sir.
Great.
So then please briefly confirm that you see the slide.
Yeah.
And you hear me?
Yes, we can hear you too.
So the topic you gave me was GLP-1 receptor agonist as treatment for NASH, fatty liver disease. Here are some disclosures. And this is my agenda. And I thought it was appropriate that I first introduce GLP-1 receptor agonists. As you know, they are derivatives of the parent compound GLP-1, which is a linear peptide amidated and is subject to proteolysis through DPP-4. And all the GLP-1 receptor agonists, starting with the natural product exendin-4, they do not have this sequence that is attacked by DPP-4, and they have some feature for prolonged pharmacokinetic profiles. For example, liraglutide and semaglutide have a free fatty acid promoting binding to albumin, and others are large molecules with GLP-1 attached, and the large protein guarantees a very slow elimination from the circulation. So semaglutide and dulaglutide can be used as once weekly injections. Albiglutide was made the same way, but it is no longer available because the company believed it was not competitive on the diabetes market. We have to see that the degree of effectiveness in lowering HbA1c is different between different agents. So generally speaking, the short-acting agents, exenatide and lixisenatide, they have weaker effects on HbA1c, and the long-acting ones have the stronger activity, with the exception of albiglutide. And one agent sticks out, and that is semaglutide, because it gives you the greatest reduction in HbA1c, and even a novel oral formulation is able to have substantial effects on HbA1c. All these GLP-1 receptor agonists, on average, make the patients lose body weight by 3-4 kilograms for most of them. Here, we do not see this systematic difference between short and long-acting agents. Albiglutide, again, is very weak in its activity to lower body weight, and semaglutide sticks out. So even the oral form, it gives you a better reduction in body weight compared to injectable GLP-1 receptor agonist. And with semaglutide, we have gotten used to weight reductions in the order of 6 to 7 kilograms on average, however, highly individually variable. We have also learned about the mechanism. So what you can see here is patients with NASH or NAFLD versus controls. And you can see that if you give them a test meal or a glucose tolerance test, then the GLP-1 response in those with fatty liver disease is reduced. And it doesn't make a difference whether you take patients with NASH or NAFLD. They have pretty much the same reduction in GLP-1 secretion, whatever that means. GLP-1 and the GLP-1 receptor agonists have the ability to not generally access the central nervous system, but there are spots like the arcuate nucleus in the hypothalamus and some areas in the brain stem where there are receptors indicated by these spirals. And within the arcuate nucleus, that's probably the most important part of the brain where body weight is regulated, there are receptors on certain neurons producing POMC and CART, and they interact with NPY neurons, which raise appetite, so they are inhibited, and there is some stimulation of the parabrachial nucleus in the brainstem, and there are some other influences from the area postrema where also these receptors are found. And that is the main reason that we see reductions in body weight. And what that means is that if you are exposed to one of these agents, and here I'm talking about the high dose of semaglutide for treatment of obesity, that will dramatically reduce your energy intake. And if you eat less calories, that will lead to weight loss automatically, even if there is no other change. And that means after a period of treating with semaglutide high dose, the original energy intake is reduced much more than with placebo. And when you ask the subjects when they have been exposed to semaglutide, then they will say they are less hungry, more full, more satiated. They don't want to eat that much. And then there is an overall appetite suppression score. So a high value indicates better suppression. And all these factors are influenced in a significant manner. And because that is so, the diabetes drug GLP-1 receptor agonists has also been tried in clinical studies in patients with obesity but without type 2 diabetes. And typically, and this is a study about semaglutide, you see more women participating in obesity trials. They have a body weight of 105 kilograms to start with. Many have pre-diabetes, which means IGT or impaired fasting glucose. And a number of these patients will have non-alcoholic fatty liver disease. So every obesity study, in a way, is also a fatty liver study. And now you see with this high dose of semaglutide that the patients over a period of more than 1 year lose approximately 15% of their original body weight. So this is more than what you have seen in diabetes trials, and that may be due to the fact that they are non-diabetic subjects and also the high dose. And what that really means is that you get patients to targets like minus 5% of original body weight, more than 85%, more than 10% reduction, 70%, more than 15% reduction in half of the patient, and even minus 20% is a realistic goal that we can expect. And a side effect of these studies was that it was observed that semaglutide here given daily and will reduce liver transaminases, suggesting that there is a beneficial effect on steatosis and the like. And this will lead to the normalization of ALT, for example, over a period of 52 weeks, in up to almost half of the patients, depending on the dose, the higher doses being more effective. And this has prompted dedicated trials of GLP-1 receptor agonists with the aim of reducing intrahepatic triglyceride. So one of the studies, the earlier studies, was with exenatide BID, and the reference treatment was just according to guidelines, and usually magnetic resonance imaging and magnetic resonance spectroscopy is used to measure intrahepatic fat, and that was done before and after exposing these subjects to exenatide or control treatment. And what you now can observe is, yes, exenatide makes the subjects lose weight. In this case, it was 5.5 kilograms. The HbA1c change was not so much different from the reference treatment, which was state-of-the-art glucose-reducing treatment. And however, only with exenatide, not with lowering glucose in other ways, there was an improvement in hepatic triglyceride content. The normal value usually is assumed to be below 5.6% of liver weight. And then they also subdivided into subgroups and found out if you lose less than 5% of your body weight, then with exenatide, you don't have a reduction in triglyceride. If you, however, lose greater than 5% body weight with this treatment, then your chances of reducing your liver fat is great. And meanwhile, numerous such studies have been performed, and they are displayed here. And this is taken from a recent review that was has just appeared in print. And you can see, especially those starting with very high levels of intrahepatic triglyceride, they have a major reduction. And the reduction correlates with the degree of body weight lowering in those studies. Small, again, relying on the body weight reduction that is observed is also seen with SGLT2 inhibitors and with pioglitazone, which has a major effect on intrahepatic triglyceride. It's the other way around, because that's probably target engagement. Those where pioglitazone is very effective, they usually gain a little bit of weight, and those who gain more have the better effect on hepatic triglyceride. But in fact, it is not only about fat in the liver, it is about the other changes that are typical for NASH and different stages of fatty liver disease. And for those, usually histology is needed. And in one study of liraglutide versus placebo in patients with non-alcoholic steatohepatitis, you can see the effect on body weight, again, like 6 kilograms weight loss, on HbA1c, on liver enzymes, and I'm not talking about the lipids and blood pressure in this circumstances. And the histological results were reported in this table. So there are many more patients with a resolution of non-alcoholic steatohepatitis, 39 versus 9%, relative risk 4.3, significant. And when you look at the components, ballooning, 61 versus 32%, significant. Steatosis, improvement in 83 versus 45%. Inflammation was not changed very much. And fibrosis, there was a much lower proportion of patients where during the period between the first and the second biopsy, there was a worsening, while that occurred in 36% with placebo. However, the difference in improvement, it was 26 versus 14%, was not significant. And another study now with semaglutide, again, with daily administration of semaglutide, thus the lower milligram doses that you see here, has been performed, and you see patients with high body mass, 35, 36. Many of those have diabetes, but not everyone. This explains the HbA1c in the diabetic range. They have elevated liver enzyme levels, and they have all stages of liver fibrosis, but very well matched between the groups. And what these people found, that is regarding the primary endpoint, and now you have to carefully listen, the resolution of NASH with no worsening of liver fibrosis. So that means you have less triglycerides, less ballooning, and so on. And the patient must have no progression of fibrosis in order to be counted here. And indeed, in a somewhat dose-dependent manner, the semaglutide-treated patients had a higher percentage reaching this primary endpoint. However, if you want to go further and ask for evidence for the improvement in liver fibrosis stage, and at the same time no worsening of NASH, that was a secondary endpoint, there was no real pattern. And although perhaps overall this was reached in a higher percentage with semaglutide treatment, this difference was not significant. And when we now look at various studies that have reported steatosis and fibrosis in studies with GLP-1 receptor and SGLT2 inhibitors, you see the improvement in steatosis in all the studies where a placebo control was available. And you can see the progression of fibrosis in the two studies that I've shown you with placebo, which was more or less reduced substantially with the treatment, of GLP-1 receptor agonists. As a supplementary method, elastography has very often been used. And when you use, this is an ultrasound method, then you can estimate steatosis from the signal that you measure. And again, you see a reduction in the signal for steatosis when you treat with semaglutide. In this case, the study with liraglutide showed a similar trend, but that was reported as not being significant. I'm not talking about the SGLT2 inhibitors. And when it comes to fibrosis, I have shown you the histology results of that study. Then apparently there is progression with placebo and improvement with semaglutide treatment, and similar differences in the liraglutide trials. So this contradicts in a way the fibrosis data we have seen from the histology in the same study, but in a way it's also complementary. In the end, I want to talk about possible mechanisms explaining the resolution of steatohepatitis and fibrosis with GLP-1 receptor agonists. And one message is important to me. And here I show you a study that probably is not correct in indicating that you can detect GLP-1 receptor messenger RNA in normal livers and at a reduced expression rate in subjects with NASH when you take liver biopsies. And the same here was shown at the protein level. I think there is general agreement that the human liver, certainly hepatocytes, do not express GLP-1 receptors. And what does this tell us? It tells us that we have to assume that any effect of GLP-1 receptor agonists on the liver must be indirect. And the first mechanism is the weight loss that I have talked about, which will reduce adipose tissue mass. And if you have a reduced adipose tissue mass, that means the fat cells can no longer release as many free fatty acids and glycerol, which could be a substrate for building lipids in the liver. Also, it means that the adipocytes will not produce as much of some of the cytokines that adipose tissue usually produces. So you have less inflammatory signals to the liver. We also have direct effect on inflammatory cells, and that will reduce the highly inflammatory M1 macrophage subtype and increase the less inflammatory M2 subtype. That will result in reduced IL-6 and TNF-alpha formation in these macrophages, which may reside in adipose tissue, and that again will have less inflammatory input into the liver. And also we have the stimulation of insulin secretion and the reduction in glucagon secretion. We have effects on the gut resulting in much lessened absorption of triglyceride in the form of chylomicrons, and insulin and glucagon will impact on the regulation of metabolism in the liver. And I think this taken all together is a very helpful approach to treating fatty liver disease, and considering that patients with advanced fatty liver disease are also at risk for cardiovascular complications. When you use GLP-1 receptor agonist for this kind of treatment, at least there is no dedicated study on that, but I think it would be reasonable to assume that this will also protect from cardiovascular complications that are commonly associated with fatty liver disease. Thank you very much for your attention.
Thank Thank you, Professor Nock, for that masterclass in fatty liver disease and GLP-1 receptor agonists. It was indeed, it was eye-opening and very, very beautifully explained. So thank you for that. I have one question, sir, for you. If you have to prioritize just one of the other, GLP-1 receptor agonists or SGLT2 inhibitors, which one would it be?
So among the GLP-1 receptor agonists, I would probably choose semaglutide because it has the greatest effects, both on HbA1c and especially on body weight. And among the SGLT2 inhibitors, although I cannot be sure that this was a chance finding, I like empagliflozin because of its reduction in mortality.
Great. So thank you for that. And thanks again for joining us today at Diabetes India. Indeed, a wonderful session. And we appreciate your presence and doing a live lecture. But in the future, we'd love to have you here in person with us as well.
That would be nice.
Absolutely. So we move on to the next talk for the evening, and that's Professor V Mohan Sir. So introducing the international expert from India, Dr. V Mohan Sir, is a moment of huge pride and privilege and honor. He's the chairman of Dr. Mohan's Diabetes Specialty Center and president Madras Diabetes Research Foundation, Chennai. His main research interests are epidemiology of diabetes and its complications, genomics, and precision diabetes, to name the least. He's been conferred fellowships from all the 4 Royal Colleges of Physicians and all 3 Science Academies of India, including fellowship of Indian National Science Academy. He's received over 190 awards, including the Dr. B.C. Roy National Award by the Medical Council of India and the Dr. B.R. Ambedkar Centenary Award for Excellence in Biomedical Research from the ICMR, and the highest award for biomedical research in India. In 2018, he also received the Dr. Harold Rifkin Award from the American Diabetes Association, and he is the first Indian to receive so. Recently, he was also conferred with the Fellowship of the Royal Society of Edinburgh from the Royal Society of Edinburgh. Published over almost 1,500 papers in peer-reviewed journals and textbooks, and has more than 160,000 citations and an H-index of 140, ranked amongst the top 2% of scientists in the world and highest ranked scientists in Tamil Nadu by Stanford University, and among the top 0.1% researchers in type 2 diabetes by Expertscape et al. He has also been conferred the Padma Shri from the Government of India in 2012 and is an author of Making Excellence an Habit, published by Penguin India, which is also a bestseller. Without much ado, he's a wonderful human being, and let's hear it from him. We have his recorded lecture, and I request RX team to play the same.
I would like to thank Team Diabetes India, particularly Dr. Banshi Sabu, Dr. Arvind, and others, for inviting me to give this talk. Unfortunately, I'm not able to attend in person, but I'm happy to give this talk virtually, a recorded talk. I would also like to thank Boehringer Ingelheim for sponsoring this talk. The topic of my presentation is diabetic cardiomyopathy outcomes, implications from Emperor Preserved study. You may be wondering why in a diabetes meeting we are talking so much about heart failure. And the reason for that, of course, you all know, is that we now have a class of drugs, the SGLT2 drugs, which have become the drug of choice for heart failure. And of course, diabetes has a lot to do with heart failure, as we will see. If you look at the global burden of the Global Burden of Disease study, the GBD study. And if you look at the CV deaths in the Indian population, I am also associated with this particular study. In 1990, only 15% of the deaths were due to cardiovascular disease. But by 2016, this had increased to 28%. It's almost a doubling. With that, the communicable diseases came down, non-communicable disease went up, and CV death alone, more than a quarter of all the deaths. And of course, these numbers are very rapidly increasing. So if you do this now in 2022, you'll probably find it's much more. It's probably more than 30 or 35% now. The national health policy goal is to reduce the premature deaths in India by 25%. So if we have any drug which can reduce CV deaths, obviously that will be of interest to us. This is a paper we published in Heart Asia some years ago, where we made the point that type 2 diabetes and cardiovascular disease share a common soil. In other words, if you look at the risk factors for diabetes and cardiovascular disease, many of them are the same. Age, male gender, South Asians are more prone to it, family history, physical inactivity, unhealthy diet, obesity, low birth weight, inflammation, hypertension, dyslipidemia. All these are associated with both diabetes, not to mention psychosocial stress and smoking. These are associated with both diabetes and CVD. And therefore, any attempt that we make at treating diabetes will have a beneficial effect on CVD and vice versa. Now, this is more recent data from the UK Biobank, where they have looked at the risk of CVD in South Asians and Europeans. Now, we have known for a long time that South Asians in general and Indians in particular are more prone to cardiovascular disease. But has this changed over time is something which is always worth looking at. And this is 2021 data showing that if you look at the risk of CVD in South Asians and compare them with Europeans, if you look at coronary artery disease, the hazards ratio is 2.3-fold higher in South Asians. 2.31 is the incidence per 1,000 patient years in the European population, whereas it's 5.12 in the South Asians, more than double. If you look at heart failure by itself, again, there is a hazards ratio of 1.83, which means that there's an 83% increase in heart failure in those of South Asian origin compared to Europeans. So there's increased risk that we have for both CVD as well as heart failure has not gone away. If anything, it is increasing. Now, if you take a prototype of an Indian patient, a typical patient that you and I will see in our clinic, 60-year-old male, non-alcoholic, non-smoker. So 2 of the risk factors already gone. Diabetic for 10 years, hypertension for 20 years. And on asking, this person says, yeah, I do get a little bit of breathlessness on exertion. Often they won't tell you, unless they are in frank cardiac failure, they may not tell you. But if you ask them, yeah, when I climb stairs, I feel terribly breathless. BMI is 29, that means he's obese. The waist is 95, that means he has central obesity. Blood pressure currently normal, but then he is taking amlodipine, hydrochlorothiazide, telmisartan. So 3 drugs already for hypertension. Now he is on metformin 1 gram and glimepiride 2 milligrams BD along with a statin, rosuvastatin. Let's look at his biochemical parameters. HbA1c is 8.1. Clearly for a 60-year-old, this is not well controlled. Fasting also slightly elevated. LDL seem to be okay with the rosuvastatin. You may argue that it should be lower in Indians, but at least it is below 100. Serum creatinine 1.2, but the EGFR seems to be okay, 69 ml per minute. However, the patient does have urinary albumin excretion of 220, so he has microalbuminuria, moderate grade. Exercise test was done, a treadmill test, and it was positive. The CT angiography was done, and it showed 70% stenosis in the LAD artery. Echocardiography showed evidence of slightly reduced LV ejection fraction, 58%, with grade 2 diastolic dysfunction, which is very common in India, by the way. We are just completing a study looking at the Scottish population, UK population with the Indian population. And this diastolic dysfunction is much, much more in our population when you age match them, duration match them for their diabetes and so on. Now, my interest in diabetic cardiomyopathy was not now after the SGLT2 drugs came. This is a paper I published in 1981. This was part of my MD thesis. I was then working as a postgraduate in Madras Medical College under Dr. Thanikachalam. And we had taken our patients from our center to the Government General Hospital in Madras Medical College to do, at that time there was no echo. Echo came after 81, after I finished my MD. So we used to do what's called as the systolic time intervals. And by doing the PEP by LVET ratio, we could show that if you look at the duration of diabetes, you can see a very large number of people having subclinical diabetic cardiomyopathy, which of course we called it diabetic cardiomyopathy because there's evidence of LV dysfunction. But this was by a very crude method, which was available at that time. But what I'm trying to say is that more than 30 years ago, we have already shown that there is diabetic cardiomyopathy in India and evidence of heart failure. Probably this is the first study from India. And as I said, it's part of my MD thesis. Now, here is a study which shows that 46% of people with type 2 diabetes have left ventricular diastolic dysfunction. It's a meta-analysis of 27 echocardiography-based studies. And as you can see, the prevalence is 0.46, which means that 46% of people with type 2 diabetes have left ventricular diastolic dysfunction. Now, this is actually based on a echo-based study and therefore much more reliable than the systolic time intervals which I had reported earlier. Now, if you look at those, the heart failure, as you know, can be there with a preserved ejection fraction, what is called as the HFpEF, or with a reduced ejection fraction, which is called as the HFrEF, or the reduced ejection fraction. And we just compare and contrast these two, and you should know this very well. The preserved ejection fraction usually occurs in older people, whereas the reduced ejection fraction is more in younger people. Females have more of the preserved ejection fraction. The reduced ejection fraction is more in males. And of course, look at this. Hypertension, diabetes, history of coronary artery disease, renal failure, obesity, all associated with both. There are some, like chronic lung disease, which is associated with the preserved ejection fraction and not with the reduced ejection fraction. Now, if you look at the prevalence of undiagnosed heart failure in those who have diabetes, type 2 diabetes, and who are aged more than 60 years, 1 in 4 people, 25%, may have previously unknown heart failure. So you'll have to look for it. It's not going to come and announce itself to you. You have to look for it. You have to use sensitive techniques, which we'll talk about later. So if you look at all patients, about 22% have the preserved ejection fraction heart failure, and 4% have the reduced. So obviously, the reduced ejection fraction is a more severe disease, and therefore, a smaller percentage of people. It's like saying microalbuminuria or proteinuria as compared to renal failure with EGFR down and creatinine high. Obviously, that will be the end stage, isn't it? So therefore, still significant percentages here. Look at males. It's almost 7% having a reduced ejection fraction. That's why I said this is more common in males, whereas the preserved ejection fraction is more common in females, as I mentioned earlier. Now, what are the clinical signs of heart failure? I'm very, nice to go through this because this is what we learned in our third year, fourth year, and final year MBBS, and things have not changed. Specific signs of heart failure, we are taught that elevated jugular venous pressure, JVP, a hepatojugular reflux, a third heart sound or a gallop rhythm, and a displaced apical impulse. These are all signs of heart failure, and they have not changed over the years. What are the symptoms of heart failure? Breathlessness, of course, orthopnea. So you're not able to lie down and you develop the symptoms. PND, paroxysmal nocturnal dyspnea, is one of the first things we're taught when we go to the third year clinical medicine posting. And reduced exercise tolerance, of course, Fatigue, not commonly recognized as a sign of heart failure, but symptom of heart failure, but that can be there. Of course, ankle swelling due to the edema. So you can have both signs and symptoms, but you must look for objective evidence. And what is that objective evidence? First of all, simple things. Start with a 12-lead ECG. It may not show you anything, may show an LVH. Transthoracic echocardiography, excellent. It will pick up heart failure. It will also tell you the ejection fraction. So it will tell you whether it's a preserved or the reduced ejection fraction. Chest X-ray, still good. I still use it. I still measure the cardiothoracic ratio, the CT ratio. The CT ratio is more than 0.5, very crude, but it still tells you the patient is in heart failure. And then today, the natriuretic peptide, about which we'll talk about, the pro-BNP and the BNP, are very good measures of heart failure. Of course, you should do the other tests like a complete blood count, kidney function test, electrolyte, thyroid function, often associated with cardiomegaly, glycemic lipid profile routine, and then iron, because the anemia or iron deficiency can also be associated with heart failure, particularly in a country like India. Now, let's talk about the use of this natriuretic peptides or NP. NP should always be used in conjunction with other clinical information. Don't take it in isolation, because sometimes you can get a false positive or a false negative results. Also remember that obese patients have lower natriuretic peptide levels, and therefore, if you use a very high levels to diagnose heart failure, you'll miss it in obese people. So you'll probably have to use half the levels in obese patients. A patient with dyspnea, this NP testing or natriuretic peptide testing has a very high diagnostic accuracy. It also has high prognostic accuracy for heart failure events in people with stable heart failure. So if you find that the BNP or the pro-BNP are increased, then the prognosis is not very good. In patients with CV risk factors, screening for these peptides may help to allow for target measures to prevent development of heart failure. Of course, you can also use it for therapy to decide whether an SGLT2, for example, can be given. And both BNP and NT-pro-BNP are equally good. We were earlier using BNP, now we have switched over to the NT-pro-BNP. Now, why should we know all this? Because in the ADA standards of care, the 2022 guidance, that means the latest guidance, they are very clearly saying that in a person with type 2 diabetes, if there is evidence of atherosclerotic cardiovascular disease or of very high risk, then either a GLP-1 receptor analog or an SGLT2 can be used, or both also can be used, okay, in this group of patients. But look at this. If there is heart failure, clearly the SGLT2 coming right on top, because the GLP-1 receptor analog do not have any effect on heart failure. So the SGLT2s have been proven to be beneficial in this particular group. Now, if you look at the three groups of drugs shown here, metformin, SGLT2 inhibitors, and the GLP-1 receptor analogs, of course, they have different efficacy, different hypoglycemic effects, and weight change, and so on and so forth, renal effects, and so on. But if you look at just the cardiovascular effects, as far as metformin is concerned, heart failure is neutral, doesn't have any benefit. ASCVD, not proven, but maybe it is useful. But look at SGLT2, definite benefit proven with the SGLT2 drugs. And for heart failure, with all the drugs, EMPA, CANA, DAPA, and ER2. But for ASCVD, EMPA and CANA stand out to be better. So you can see that EMPA is there in both. It's the one drug which can be used for both. And of course, the GLP-1 receptor analogs have no effect on heart failure. They may have some benefit for ASCVD, particularly dulaglutide, semaglutide, and liraglutide. How do the SGLT2s work? They work on three particular sites. First is they work on the preload reduction. Then they work on the heart itself, on the myocardium, and then the afterload reduction as well. So you know that cardiac failure can be preload or afterload or effect on the myocardial function itself. On all the three, SGLT2s are shown to be better, and therefore it results in improved cardiac structure and function. Now, these are old data, which all of you know from 2015 onwards, where you can see that if you look at empagliflozin, and it offers very early risk reduction benefit for CV death in those with ASCVD and type 2 diabetes. This is the EMPA outcome trial, where you can see this is the placebo arm and this is the EMPA arm, and you can see when the graphs are beginning to divide. Just when you start giving, within the first 28 days or 1 month itself, you can begin to see the graphs divide, which means that there is a reduction in the events which occurs very early. No other drug has actually been shown to do this, including any other drug which has been used in the past. Now, do Asian patients respond as well? If anything, it is even better. If you look at the overall study population, hazards ratio is 0.62, which means that there is a 38% reduction. Look at the Asian group, it's 0.44, which means there's a 56% reduction. So Asians are doing better. And of course, you would have seen our paper in the diabetes care showing that the SGLT2 drugs do better in Asians, including Indians. Now, let me just now move on to the Emperor preserved study. So very few studies have looked at heart failure in those with preserved ejection fraction. And what they did in this trial was they took patients with heart failure, but with left ventricular ejection fraction more than 40%. So we had the empagliflozin arm as well as the placebo arm. And then we had a primary endpoint looking at the time to first event of adjudicated CV death or adjudicated heart failure, hospitalization heart failure. And then there were secondary endpoints, including some of the renal events as well. This is called as CKD-EPI. Now, if you look at the those with the reduced ejection fraction and the preserved ejection fraction, this is the baseline demographics of this group. Well, to be honest, there were some statistical differences between the groups. Naturally, when you look at those with the reduced ejection fraction, they are a little bit more severe. So look at their pro-BNP, anti-pro-BNP, higher than those with the preserved. And again, certain other things are a little different between these two groups. But having said that, these differences are very marginal. You can see 70.1 years, 72, very, very small differences between the groups. But the point that I'm trying to make here is that empagliflozin showed consistent efficacy both in the group with the moderately reduced ejection fraction, 41 to 49%. So everybody had above 40, but then it was further subclassified into ejection fraction between 41 to 49, which is called as moderately reduced ejection fraction, and more than 50, which is preserved ejection fraction. And you can see the hazards ratio, 0.71 here, showing that there's a 29% reduction, statistically significant, between the placebo and the empagliflozin arm. And if you look at those with the preserved ejection fraction, a similar difference, 17% reduction, again, statistically significant. And the numbers needed to treat are given here, 21 and 42 cases. Now, if you do a sub-analysis, now a stratified analysis, what we call as, and if you look at it, males, females, was it significant? Now, anything on this side of the unity line there means it favors empagliflozin, and if it comes on that side, it favors placebo. So you can see males and females are on this side. We have diabetes, no diabetes on this side. EGFR, more than 60, less than 60 is on that side. Whether they had a history of atrial fibrillation or flutter, it made no difference. Irrespective of what stratified analysis you did, it favored empagliflozin. That means across the board, empagliflozin was effective. Now, next question that you'll ask is, were there any side effects? Because, this euglycemic ketosis and all that has been talked about with the SGLT2 groups. What about hypoglycemia? Look at ketoacidosis. 0.1% empagliflozin, 0.2 in the placebo. So no difference at all. Similarly, with hypoglycemia, no difference at all. So virtually no difference between the two groups. And therefore, of course, you'll find a little bit more gentle infection that we know, 2% and 0.7%. So that is slightly more, but otherwise no other significant differences. So therefore, after this trial was over, the Emperor Preserved trial was over, 2021, you can see that right from the Charm Preserved trial, there are different drugs which have been used for treatment of heart failure and preserved ejection fraction. Candesartan is used, perindopril, irbesartan, spironolactone, and ARNI, all have been used. Now, a new drug added for the treatment of heart failure with preserved ejection fraction, a completely new group of drugs being used. And you can see that the hazards ratio for the benefit was probably the risk reduction. You can see that minus 21%. All the others are 8%, 5%. These are the regular treatment for heart failure, which cardiologists and physicians have had all these years. The highest was only 14%. Now we're getting 21% reduction, risk reduction with empagliflozin. So it's, apart from being a diabetic drug, it has now turned out to be a superb drug for treatment of heart failure. Now, again, if you look at now, if you add that data onto this and look at all the data for EMPA that we have for treatment of CV death or hospitalization for heart failure, these two endpoints, if you take, if you just have type 2 diabetes and your CV risk is low, there is a reduction in the CV death and hospital heart failure. If you have just atherosclerotic heart disease, it works. If you have atherosclerotic heart disease with prior CV event, it works. If you use heart failure with preserved ejection fraction, it works. If you take with moderately reduced ejection fraction, it works. And if you have with markedly reduced ejection fraction, it works even better. So as the risk increases and you get more and more severe heart failure, the reduction also improves. Naturally, this is not so. People may ask, so shouldn't we use it in those who are normal? That doesn't mean anything at all. It is still having effect there. Now, it's like if your starting HbA1c is 11%, you will get a 4% reduction if you use any drug. If your starting HbA1c is 8% or 7.5%, you will get only a 0.5% reduction. It depends on the baseline, isn't it? So similarly, if you have severe heart failure, it works much better. Whereas if you don't have it, it still works. So empagliflozin can be used in any type 2 diabetic patient from the time of diagnosis till late stage and irrespective of the severity of the heart failure. And therefore, it is not surprising that the American Heart Association, American College of Cardiology, in their recommendation 2022 guidelines, I'm giving you all the latest guidelines. Look at this. Their recommendation is in patients with type 2 diabetes, this is hypertension general population. We are concerned with type 2 diabetes. In patients with type 2 diabetes in either established CVD or at high cardiovascular risk, SGLT2 inhibitors should be used to prevent hospitalization for heart failure, period. They've given it like that, black and white, they have given it. And these are not by the Diabetic Association people, but this is by the American Heart Association, American College of Cardiology. And this is for primary prevention for patients at risk for heart failure. This is to prevent heart failure. What about those who already have heart failure and preserved ejection fraction? Again, the guidelines are very clear. In patients with heart failure with preserved ejection fraction, SGLT2 can be beneficial in decreasing heart failure hospitalization and cardiovascular mortality. The writing on the wall is very, very clear. So with that, I would like to thank the